este tema es inhibidores de proteasa en la práctica clínica, la experiencia en Alemania. Doctor, can I start with your talk?
Thank you very much for the kind introduction, Edgar, and also thank you for the invitation to Antonio. I'm very happy that we, for once, pick up another topic, one of the drug classes that we have a lot of experience with, but often actually do not really talk about, and it's the HIV protease inhibitors. Now that everyone is focusing on dual therapy, integrase inhibitors, etc., they always tend a bit fall off the table. So first of all, I'll start with my conflict of interest. And then I would like to draw your attention. I'm very aware that most of you probably won't be able to read it, but this is the front page of the German guidelines on heteroviral treatment of HIV-1 infection. And I just brought this up because we have a lovely table in these guidelines, which is on the next page here. And that gives you all the combinations that can be given to people who are newly diagnosed with HIV. So it's treatment naive setting. And you can see on the top, just by the abbreviations, we've got several single tablet regimen approved that we can use in the naive setting. And there are a lot of integrase inhibitor-based regimens, but also in an RTI-based, including doravirine, but also one PI-based regimen. And that's why I brought this slide up, because in Germany, a protease inhibitor treatment is still a valid option in treatment-naive setting. And that's in contradiction to the WHO guidelines, as well as in contradiction to the European AIDS Clinical Society's guidelines, who all focus on integrase inhibitors as the cornerstone for first-line treatment. We are a bit different in Germany. We allow all three drug classes to be used in the treatment-naive setting, and of course in switch as well. So before we dive into more data, and I'm very aware that when we talk about HIV protease inhibitors, most of our discussions and the talk will probably focus around darunavir, because boosted lopinavir is hardly used anymore in Germany, and the percentages of patients being on boosted atazanavir are very minimal as well. So apologies up front. Most of this talk will actually focus on darunavir being the #1 prescribed protease inhibitor. So this slide contains two studies. That's fresh data from this year's CROI, the retrovirus conference that was held virtually. #1 on top is the advanced study. 104 ART naive patients were treated with either dolutegravir, so an integrase inhibitor, or boosted darunavir plus ABC3TC. So it's the comparison of an integrase inhibitor or proteinase inhibitor-based regimen in advanced patients, so below 100 helper cells at diagnosis. And you can see in the table to the right that overall there were no statistically significant differences between the two treatment groups, and there was only one subtle discrimination between the two groups when it comes to treatment discontinuations. The rate of treatment discontinuation for any reason was a bit higher in the darunavir containing arm, but it's very noteworthy to say and see that the viral decline was initially faster under dolutegravir, but at the end of week 48, the rates of virologic suppression remained the same. The second study that I wanted to show you is the SYMTRI study, again in ART naive. And these patients, 316, were randomized to either boosted darunavir, cobicistat boosted darunavir FTAF, so fixed dose combination, single tablet regimen, versus abacavir 3TC dolutegravir, so well, again, an STR fixed dose combination, single pill. Median CD4 was quite good, and you can see, if we cut it short, if you look to the right, response rates were similar for both treatment groups when it comes to virologic suppression after 48 weeks. And a slight off note, because we are all very much focused on weight gain and weight change these days, the graphs to the right contain the weight development over 48 weeks. And both regimens were the same when it comes to weight gain. And I think that's quite interesting because one regimen contains TAF, which is quite often blamed for weight gain, and the other one doesn't, but that then contains dolutegravir. But I think with that we can quickly agree that the treatment-naive setting is probably not the best setting to focus on weight gain and weight changes, because as you will all know, the majority of our patients gain weight just by treating the energy-consuming HIV infection. One study that's currently still running, worldwide, initiated from the NEAT-ID Foundation, is actually the head-to-head comparison of an integrase-based single-tablet regimen versus protease-based single-tablet regimen. So it's Biktarvy versus Zymtuza in the setting of advanced HIV infection. So below 200 helper cells and or age-defining illness over 48 weeks. And that study is still ongoing. It's called Laptop. And we are all very curious to see what the results will be, if there are any benefits in terms of safety or efficacy, iris development, etc., when it comes to comparing protease versus integrase. So let us remind why we are still keen to use protease inhibitors, and I think that's one of the reasons why it still is in the German treatment guidelines. That's a summary of 10 clinical studies assessing boosted darunavir once daily. And you can see in the graph to the left that the chances of resistance development under protease, under a boosted protease inhibitor regimen are close to minimal. So it's small percentages, 5 out of close to 4,000 patients, that's 0.1% that actually develop a resistance. So the chances of developing a resistance to the protease inhibitor or the NRTI components is very minimal. The second beauty of the fixed dose combination, kubiciclib boosted darunavir plus 2 NRTIs, FTAF, is also, of course, that you're getting rid of the TDF and you can treat patients with the when it comes to toxicity, more friendly tenofovir alafenamide. And that's a table from a meta-analysis done by Andrew Hill. And this is focusing on the efficacy and safety of TAF in boosted regimens, so boosted protease inhibitors, as well as the boosted integrase inhibitor, Stribert or Genvoya. And if we cut it short, you look to the right to the significance levels, you can see at the bottom of the table that the TAF regimens did better when it came to bone fractures, when it came to discontinuations for bone AEs, and also when it came to discontinuations for renal AEs. So this single pill also offers the advantage of being combined with a good and very tolerable NRTI component. And the third issue, and that's just something that I mentioned, is that we have the co-formulated version available, 2 NRTIs and a boosted protease inhibitor. And I think it's worthwhile to note that with the emtricitabine, which has been on the market for more than 17 years, we have a lot of clinical experience. And we've just seen the benefits of TAF over TDF. And I've shown you the resistance data for darunavir, why it's a good choice. Still is a good choice as first-line treatment. So to give you an overview, what the freshest data are in this field when it comes to boosted protease inhibitors, and again, that's very much focusing on darunavir, I must say, because for the other 2 regimens, there's hardly any data or study being reported. And I picked out 2 trials that I would like to shortly show you, and then maybe we can end up at the end and discuss this. It's the AMBER and the DIAMOND trial. So we start with the first one, that's the AMBER trial, including ART naive patients. So that's still the naive setting, 725, viral load above 1,000 copies. And the patients were randomized either to directly DCF-TAF or to boosted darunavir plus FTDF. And then after 48 weeks, these patients were rolled over into the DCF-TAF arm as well. And then from week 96 onwards, patients were only treated with DCF-TAF. When we look at the results and the baseline demographics and the disease characteristics that's shown here in the table, you can see that's a rather young patient population, so median age is 34. Unfortunately, not a lot of female participants, as is quite usual in the HIV trials, only 12 or 11%. Predominantly white male study population, at least 17 to 19% had a viral load above 100,000 copies at baseline. CD4 T cell count was still okay, 461. And the genotypes at screening revealed NNRTI-RAMs in 16%, NRTI-RAMs in 5%, and primary PI-RAMs only in 2%. Sorry, that's one too fast. If we now look at the results, that's week 48 result and 96 FDA-Snapshot, so also including missings that were counted as failures. And the blue ones, the blue bars, are the ones that were put on boosted darunavir plus FTAF from the very first start. You can clearly see that good response rates and clearly non-inferior to the comparator arm with FTDF for both cutoffs, viral load below 50 copies to the left and viral load below 200 copies to the right. If we look at subgroups, that's always interesting. I already mentioned that only a small proportion of females was enrolled into the study, unfortunately. So if you look at high or low baseline viral load, and the cutoff was 100,000. If you look at high and low baseline CD4 T cell count, below 200, above 200, the age cutoff would be 50, gender, female, male, and then race. You can see that across all these subgroups, the DCF TAF arm performed as well as did the control arm. Of course, we have to talk about resistance. I already mentioned that the likelihood of developing resistance is quite low, and that also holds true for the EMBER study results. 9 in the DCF TAF arm and 8 in the FTDF arm had a protocol-defined virologic failure. And very fortunately, no darunavir primary PI or TAF tenofovir arms were observed post-baseline. So no resistance development. The downside of protease inhibitors is, and that's something I think we have to discuss and we'll discuss later on in the discussion, is the higher likelihood of adverse events. I already mentioned that on one of the first trials, there was a higher rate of discontinuation in the patients receiving a boosted protease inhibitor versus the ones that ended up on an integrase inhibitor. And the side effect profile is the one that you would expect. You mostly end up with diarrhea in 9%, then the usual darunavir rash because of the sulfonamide part, and nausea, etc. So nothing really excitingly new. When we then have a look at lipids, because the booster, the copistat, of course, is not very lipid friendly. And again, the higher bars here now, the blue bars, reflect the patients that were on DCF TAF from baseline onwards, and they ended up with higher lipids, total cholesterol, LDL, HDL, triglycerides, as well as the ratio. And I'm very sure that we will have a short discussion about that at the end of the talk. The second area that we would need to touch, because this is also comparing TAF versus TDF, are the changes in serum creatinine and the GFR based on cystatin C. And you can see what we have now seen in a lot of trials, that under TAF the creatinine clearance is better. In this case, it goes down because the copistat does have an effect on the creatinine secretion. And when you look at the cystatin-based, you end up with a better GFR when compared to the FTDF arm. So, but that's nothing really that striking and surprising. That's something we've known before. Then very luckily, they were able to do DEXA scans, checking for bone mineral density. And the DCF TAF arm performed better over 48 and 96 weeks when it comes to the bone density in the hip area and also the lumbar spine. So the second study that I wanted to talk about, we'll start with a short teaser. So here now it's 10:30 in the evening. So I will have clinics I start at 7:30, so like several hours I will start my clinic and tomorrow, and I hope you will do too. And let's just assume that we end up with a 38-year-old MSM who just got his HIV diagnosis this week, CDC stage A2, medium high viral load above 800,000 copies, CD4 T cell was 212. And he also, when seeing him tomorrow morning, he also says that he has got an HIV new partner, and this partner has been tested HIV negative. So you might already guess where we are moving to, which area. And I just wanted to bring to your attention because that's highly discussed, particularly from the AIDS community, the risk for zero transmission once you are below this threshold of detection, and that's 200 copies. It's not 40 or 50, it's 200. And one of the pivotal papers in this area is the paper from the partner study, where they saw no HIV infections within same-sex couples within the partnership if one of the partners was HIV infected, was below the threshold of infection. So that's very reassuring and has been used. I just told you that the community has really jumped on this topic for very good reasons. But this is German, I'm very aware that you won't read, but I just wanted to show you that they started media campaigns 2 years ago and are still going out in the scene and doing talks and YouTube videos to, that's what it says here, double your knowledge, Wissen verdoppeln. So you have to get, you get new information now on the infectiousness of well-treated HIV patients, which is actually zero. And I put this in here because the question then is rapid ART start. And I would actually be quite keen to have a discussion at the end, what your take in Latin America, Mexico, etc. is on rapid start, because it's not that much of a big issue here yet in Germany. But if you would like to start rapidly in Germany, we have clear recommendations for 3 regimens that are listed here. 2 are integrase-based, and won't surprise you because that's the talk of the title of the talk. There's also one darunavir-containing option, so the Zentusa can also be used as a rapid start option. And why is that? Because there's actually quite good data, which I will show you. And you can also select a PI because the risk, at least in Germany, that someone who is diagnosed with HIV and you don't have a genotype resistance test back yet has primary PI resistance, the chances are very low. That's the lilac, the purple curve here on the figure. So overall prevalences of resistance in Germany are quite low. It's around 10%, and then it's mainly referring to NRTIs followed by NNRTIs, and then to a much lesser extent PI and hardly any integrase resistances. So the study that has generated data with regard to rapid start is the Diamond study, and they've enrolled 109 newly diagnosed HIV patients with either acute infection, that's written below, and they were still HIV antibody negative and RNA or P24 positive, acute infection or early infections, so already antibody positive, and a suspected infection of less than 6 months before screening baseline. And they were put on DCF-TAF for 48 weeks. So if you look at the baseline characteristics of the 2 groups, early or acute infection, you can see that clinically we end up seeing more patients with an early infection and to a lesser extent with an acute infection, because those are often missed or present later for diagnosis. It's a young patient population, median age 28, almost men. At least a quarter of them had a very high viral load, particularly in the group with the acute HIV infection. CD4 T cell count was quite okay, but a substantial proportion was also below 200 helper cells in the very acute, highly viremic phase. And the time from diagnosis to screening baseline, so enrollment into the study, was median 5 days. And at least 31% were enrolled into this trial within 48 hours of the HIV diagnosis. And that's, I think, can be considered a rapid start. That's the results. The virologic suppression rate at week 48 in blue for all patients, and then in light green for the ones with the acute infection, and in dark green for the ones with the early HIV infection. And you can see good response rates after 48 weeks. And if you take out the ones that didn't have any data available at week 48 because they moved to another country, were lost to follow-up, etc. So really look at the ones that had data available. Then, as usual, the response rates get even better and very convincingly end up above 90%. And I think that's something we would like to see and expect when treating HIV infection very early. So those were the two studies I wanted to show you with regard to the naive setting, but of course the protease inhibitors also come into play in the switch setting, given that HIV treatment has to be given lifelong, and at some point that the current treatment might require changes to then other options. And the one trial I would like to show you is the Emerald trial, focusing on suppressed patients. And these were randomized in a 2-to-1 ratio to either, again, darunavir, apologies, but that's the most studies we'll get these days. Hardly any are done with atazanavir and 0 with lopinavir. So it's again DCF-TAF or continue to boost this protease inhibitor plus FTDF for 48 weeks. And then the green group was also switched to DCF-TAF, and then the rollover phase started. They had to be on their Boosted regimen for at least 6 months, had to be virologically suppressed, no history of previous ART failure. These are the baseline characteristics, and now this patient population, of course, is older because they have been diagnosed quite some time ago. So median age is 46. Luckily, a bit more females enrolled this time, 18%, predominantly white. The median years since HIV diagnosis was around 9.3 years. Good CD4 T cell count of 630. Prior virologic failure was documented in 15%. And when you look at the regimens that the patients were on at screening before they were randomized, it was already mainly darunavir, but most of them boosted with ritonavir, not with cobicistat. Followed by atazanavir, and that again mainly boosted with ritonavir, not with cobicistat, and only a subfraction was on boosted lopinavir. So when we have a look at the week 48 FDA-Snapshot analysis, and also, which is an analysis they have nicely done, on the cumulative virologic rebound. So how often do you actually see the blips in these two study arms? And that ended up with 2.5 and 2.1% in both study arms. It was not very high, which is very comforting given that protease inhibitor regimens tend to lead to blips once in a while. To the right is the FDA-Snapshot analysis. And again, very good response rates, also suppression rates over 48 weeks for both treatment groups, and then the usual no virologic data available in 4 to 6%, and a very small number of patients, 6 and 2, that had viral load above 50 copies at the week 48 study visit. When we look at the week 96 data, so 1 year longer, again, the virologic efficacy stays the same, still above 90% both study arms. And then if you look at the time point where everyone in the study was then put on DCF-TAF, then the response rates are around 94%. So even on the long run, very good virologic suppression rates. And again, as seen before in the naive studies, no resistance development to darunavir, tenofovir, or FTC. And no primary PI RAMs were observed after study start. So very reassuring. Adverse events now have to be talked about, and that's again the usual things you would expect: diarrhea, headache, abdominal pain, and a bit of osteopenia. In general, very low numbers across all study arms, and then the usual adverse events that one would expect under a boosted protease inhibitor regimen. That also applies to the lipids. So the control group was on FTDF, and that usually has a lipid lowering effect. And as a result, the fasting LDL cholesterol was significantly higher in the DCF TAF arm, and the phosphate was slightly lower. And then there was a bilirubin signal, but that reflects just the patient in the control group over here being under boosted atazanavir. When we now look at the mean changes in GFR, both based on serum creatinine or cystatin C, again, that's something we've seen in the naive trials as well. The usual decline under TDF-containing regimens, and the rather neutral curve lines under TAF-containing regimens, keeping in mind that the kubicizumab in the boosted combined formulation inhibits the tubular secretion of creatinine and then falsely lowers the results of the GFR. The second last thing I think we should talk about is then, of course, the hip and spine bone mineral density measurements, because they also did DEXA scans in this trial. And again, the TAF containing arm did much better already over 48 weeks, so already over 1 year compared to the control. And that applies for both regions, for the hip as well as the spine region. And then before we enter the discussion, that's a review I stumbled across the other day, and that is listing, has nothing to do with protease inhibitor, that lists potential advantages and disadvantages of very new HIV drugs that can probably be delivered subcutaneously or as implants or injectables. And they made a list of advantages and disadvantages, and I just put this in here because I wanted to a bit stimulate the discussion that with all these new regimens, we might actually end up seeing resistances that we haven't seen before, because we are now entering new drug classes, the capsid inhibitor and lenacapavir, for instance, who does not seem to have a very strong threshold against resistance development. So at some point, I think we might end up with the drugs that we've known for quite some time with a higher barrier to resistance development. So in summary, I hope I could convince you that HIV protease inhibitors are still standard of care and in both settings, naive patients as well as in switch patients. And then, but that's my personal view, and I'm very happy to be yelled at for that, I think that future ART regimens, particularly the implants, injectable subcutaneous solutions, might generate the need continuing need for HIV protease inhibitors to be used in clinical life due to development of resistance in new areas of drug classes. Thank you.
Thank you very much, Doctor, for your excellent presentation. There are some questions in the public. Dr. Antonio Mata.
Yes, thank you for your nice presentation. Here in Mexico, we have some choices, fortunately, in some hospitals, like the use of the ribavirin, the use of Prescovix. For example, when do you use in your clinical practice darunavir cobicistat? Is for some special patients, but because we know that, for example, for a patient that is in the first failure with integrase inhibitors, I think darunavir cobicistat is perfectly. We don't have opportunities to do genotyping in every patient. Then for in a patient who failed for integrase inhibitor or maybe for a non-nucleoside like efavirenz, we don't have so much efavirenz right now, but in some clinics they continue using efavirenz. Then when efavirenz or when an integrase inhibitor fails, we can use doravirine cobicistat like a perfect drug in that case. But in your clinical practice, do you use darunavir cobicistat in another situations, as you mentioned, for a rapid to start antiretroviral therapy, or maybe with another problems? Because when we have patients here in Mexico with metabolic syndrome, that is very common, as you know, the obesity in Mexico is 75% of our patients are with overweight or obesity, or with problem of central nervous systems, depression, anxiety. But in this case, we have, okay, I can use a protease inhibitor, or I can use a drug like doravirine. That is a good choice too, maybe in these cases. Maybe doravirine cobicistat with drug-drug interaction could be a problem. But what do you do in your clinical practice when you say this is a good patient for darunavir cobicistat?
So Zymtuza actually is my preferred choice in patients who are on substitution therapy, methadone or something else, because my experience is, and that's what the patients tell me, the opioid does lead to constipation, and the maybe side effect of diarrhea actually counteracts the side effects of the opioid and the methadone, so that you can sort of regulate their stool just by giving those two together. And then I think I'm really curious, that's why I put it in there, what the laptop trial will tell us. That's the one comparing BF-TAF versus GCF-TAF in the setting of advanced infection. If there are any benefits in terms of adverse events or iris, we all remember that there were iris signals under integrase inhibitors because the viral load goes down so quickly, and then other germs can take over, and that maybe triggers more sort of iris events other than under protease inhibitors, where the curve of the virus is a bit slower and the system takes a bit longer to sort of recover without really putting someone at risk. Well, and then if I have someone, as you just mentioned, who I think has the tendency to accumulate CNS problems, so someone with a severe migraine or a history or current depression with already 2 drugs just to treat his depression, maybe then that's not the ideal candidate that you would put on an integrase inhibitor, because they clearly do have the tendency to cause additional CNS toxicities, and maybe then give it a try with the protease inhibitor. The only thing really is the lipids. That's something you really have to keep in mind and keep an eye on. If they really go up to a level where you think that's not tolerable and you need to intervene. If you do already have a patient that's on a statin, then I think that shouldn't be an additional risk, because you're already treating the hyperlipidemia anyway.
Perfect. My second and last question is about when do you use, for example, darunavir cobicistat with dolutegravir, darunavir cobicistat with 3TC? Do you think there is some place in the HIV treatment for this kind of regimens that are like very for patients with cardiovascular risk, or I don't know, maybe to use some bitherapy opportunities with darunavir cobicistat?
We have been using this for quite a lot, particularly in our rather treatment experienced patients, because they develop NRTI resistances at some point. So you can't really put them on any drug plus 2 NRTIs, because that's not going to work. And those are the typical patients that get a protease inhibitor boosted, and then an additional drug. And now that we have doravirine available, and we already talked about this at the 2DR talk a couple of weeks ago, the combination of doravirine with either a protease inhibitor or an integrase inhibitor as a 2DR strategy to treat patients NRTI-free, be it because of resistances or be it because you are convinced that the weight gain issue with NRTIs is really true.
Thank you, Christophe.
Dr. Gesser Lezama has a question. ¿Estás acá, Gesser?
Hola, sí. Hi, congratulations, doctor. Very excellent talk. And I have some questions. My question is related to switching patients. Mm-hmm. Here in Mexico, we see a lot of patients with exposures to a lot of protease inhibitors, and that patients are on optimized background therapy with darunavir at double doses, and they are chronic suppressed and very well, no? The problem with that patients is that they use a lot of pills per day. Mm-hmm. And clinical data tell us that maybe in chronic suppression, it's possible to switch, including protease inhibitors. Do you think, or if you have experience, I want to know yours. What is the safety to switch a patients to double dose or darunavir to the dose of 800 milligrams in this context? I mean, for example, using dolutegravir plus Prescovix plus another drug to switch the optimized background therapy?
That's an excellent question, and we have these questions as well. So if you have patients who are on 600 milligrams twice daily plus the 100 milligram Norvir, that's already 4 pills plus the other HIV pills, and then they're usually patients above 50, so they have other pills on board, so they end up with a dozen pills per day that they have to take, which is quite a nightmare. So the question if they can be put on an STR with the 800 milligrams is very valid and can be done if a patient is virologically suppressed and you don't have any documented protease inhibitor resistances. The rest doesn't really matter, but if you really have a failure in the past to protease inhibitors, which is not very likely, then you shouldn't do it. In all other cases, that you can give it a try and reduce the pill burden, which also makes the adherence better, etc.
Thank you. And related to these patients that we need to use dolutegravir plus Prescovix, and for some reason we need to use tenofovir. In talking about TAF, and as we know, we use 25 milligrams with INSTI and 10 milligrams with IP. Which dose would you prefer, or are you feeling comfortable to use 25 milligrams with IP?
Well, if we use it as an STR, then it's already inbuilt in the protease STR, and then it's the 10 milligrams. And I think that's very valid to do because the levels will be the same because the cobicistat will push the levels higher, and then you will end up with the 10 milligrams. And if you use the STR, that's already what's in there.
Thank you very much. That's all. Thank you.
Okay. Other question, doctor. In Mexico, we don't have Sintusa or darunavir in a single tablet regimen. In your opinion, in young healthy patients, TDF maybe is an adequate combination with darunavir, or tenofovir alafenamide is preferred in young healthy patients?
Well, TAF has clear advantages, but I must say that's already a very good tale of marketing that the company has told us. So over 10, 15 years, we were told that TDF doesn't do anything to the kidney and the bones. And as soon as there was a newer drug on the market, everyone was telling us that's the worst we could ever give to our patients. And then again, we are all very happy to put our HIV negative patients on PrEP, and they have to then take FTDF. So of course, in someone who's younger, doesn't have any significant comorbidities, FTDF is very doable. So in women postmenopausal, I would be cautious because they have a high risk for osteopenia or osteoporosis, and in chain smokers, because smoking really does something to your bone mineral density. So you get osteopenia. So in young MSM who are really chain smoking for whatever reason, they can't stop. I would be a bit more hesitant, but of course you can use FTDF with the usual controls. We've been doing that for 15, 20 years.
Okay, thank you. And other question, is there any information on darunavir covistat every 12 hours in experiment patients? Darunavir covistat 2 times today, and not darunavir ritonavir.
Sorry, I don't get the question. If the covistat is better, or?
Darunavir covistat 2 times today or every 12 hours in experienced patients.
Instead of the ritonavir, you mean? Yeah, is an option, yes. Depends a bit if you have it available. So the funny part in Germany is that we have the STR available with everything, so it's DCF tough, but we don't have the combination of darunavir covistat as a fixed dose pill, because apparently they assume that Germany wouldn't be a big market for that. But of course, yes, you can do that as well, yeah. Okay. And some people tolerate the covistat better than the ritonavir.
Okay. ¿Alguna pregunta en el público? ¿Alguien más que quisiera preguntar? Puede hacerlo directamente o escribirlo en el chat. More questions. Okay. Ok, doctora Jessica Holguín ya puede hablar.
The mic's still on mute.
Ya, sí. Doctora Jessica ya tiene aperturado para hablar, solo active su micrófono. No. Maybe it's equivocated.
If not, we do later on with an email.
Okay. I no see more question. Okay. ¿Alguna otra pregunta? Creo que no. Okay. No more question, doctor. Thank you very much for your excellent presentation. Very relevant information. It's okay. Okay. No more question. Thank you very much, doctor.
Thanks a lot.
Bye. Good afternoon in Mexico. Good evening in Germany.
See you soon. Bye.
Bye.